Today I want to talk about the pros and cons of nursing in the operating theater. I have recently gotten some questions from some of my friends that then they were curious to know how operating theater nursing was like compared to their specialties, which is not operating theater at all. And I think this would be very good for not just answering questions to them, but also this would help other nursing students or practicing nurses interested in making a switch to the operating theater. So I wanted to share this video based off of my experiences. Because these are my specific experiences, things might be slightly different for each individual, but overall they should generally be the same within the specific specialty or domain. In no particular order, let's get to it. A con to operating theater nursing is nursing school doesn't do a good job in teaching students about the operating theater and also length of training it takes to become an operating theater nurse. Because nursing school doesn't integrate the operating theater into the curriculum, the vast majority of nurses end up getting insight into fields like med-surg, step-down, emergency department, intensive care units, or outpatient clinics for both the pediatric and adult populations. Because of this lack of insight, when nurses do make the switch to the operating theater, they end up undergoing the longest training length than any other nursing specialty. Some programs have anywhere from a training program lasting all the way up to 8 months, but most programs are generally around 4 to 6 months, with many nurses not really being comfortable on their own in the operating theater until about a year of realistic training and experience. A pro is the patient ratio. So in the operating theater, what many would be surprised to know is you're only taking care of one patient at a time. That's it. In other specialties like the floor or med-surg, nurses might be taking care of anywhere from 4, 6, all the way up to 8 patients even, which can be a lot of pressure and can really be overwhelming at times, and is kind of one of the reasons that is making floor nursing very prone to nurses leaving that specific specialty. I remember when I was in the med-surg floor, in my rotations, I was taking care of 3 patients up at one time, and it felt very overwhelming and very exhausting. But in the operating theater, it's a 1 patient ratio the entire time, which alleviates a lot of that stress and burden of having to take care of multiple patients. And the other thing to that is when you're on the floor, you're going to have active and alert patients for the most part that will be kind of demanding, or they might behave in a very rude manner. In the operating theater, you don't have to worry about that at all, because whilst you're taking care of that patient, they'll be completely knocked out under anesthesia throughout the surgery. A con is a turnover for the cases. Some days in the operating theater, nurses would be felt a little bit rushed with the surgeries. And that just means that there might be multiple cases that day that need to get done at a specific time. Maybe they might get done sooner rather than later because the previous surgery or the current surgery is taking longer to finish than what was expected. That kind of creates this urgency of more of hustling and having to rush through things instead of not taking the appropriate time to do things. But generally speaking, when I was doing this in my experience, it really wasn't bad or too overwhelming. It was just kind of an annoyance. But that is a con in the sense that although you're taking care of one patient at a time, you're still going to be doing a lot of turnovers. A pro is the pay. Out of all the other specialties, the highest compensation is in surgery. Therefore, it is no surprise that for nurses who are in the operating theater, they make the most amount of money compared to other nurses in other specialties, whether it's the intensive care unit, the emergency department, the step-down unit, the med-surg unit, outpatient clinics. If you want a lot of money, operating theater is the way to go. You're going to make a lot of money when it comes to the salary and also the hourly rate. I've already seen it so far, but I have some nurses in my hospital that told me they make more per hour than nurse practitioners, physician assistants, and some physicians as well. But generally speaking, they have decades of experience. But it is kind of a field where you can really make a lot of money for not doing a lot of strenuous activity. Currently, me specifically, I'll share this. I currently make $41 an hour starting out as a new grad in the operating theater. Many of my other friends who graduated nursing school, when they went to the emergency department, med-surg unit, ICU, or outpatient clinics, they're barely cracking out at $30 an hour, maybe a little bit more. But that's just to kind of show you they get paid a lot. A con is the surgeon personalities. Some surgeons in the operating theater can basically act like a, you know what, they can cause some issues of distrust. In my case, I haven't come across any surgeons yet who kind of behave like grumpy old children. Most of the surgeons at my hospital, they're genuinely patient, and they really want to teach you surgery if you're genuinely interested in it. And that's something I really enjoy so far. But just to be clear, there are going to be some cases where you might have surgeons who are very impatient. They don't care if you're a new grad or if you have 50 years of OR experience. They're still going to behave the way they behave to you and to any other doctors or any other people within the operating theater. A pro is the medication administration. In the operating theater, you'll only be preparing one of the same kind of medication over and over again, and that's going to be some type of local anesthetic, such as lidocaine, bupivacaine, or Marcaine. And that is a really big relief off the shoulders of someone. And you're not only giving that medication, because you don't as a nurse, you are only prepping it and you're just putting it on the sterile field. So the surgeons are the ones that actually administer and give the medications. Your job is only to make sure you prep it and make sure it's the right dose, the right name, and it's not expired, and it's given to the right patient at the right time. I remember when I was doing my clerkship rotations on the floor, I was giving about 25 to 30 different medications per patient, and these weren't similar medications. Sometimes they were completely different ones. And as a floor nurse, you had to note before you were giving your medication to the patient what they were. So I was constantly stressed with having to know all these different medication names, what they do, and that would take hours and hours of time just for me to get accustomed to it, and that really overwhelmed me and my experience in the floor. But in the OR, you're only giving generally one or two of the same medications. If the surgeon requires more of that, they're just going to tell you to get more, and you do the same process. So it's super easy and it's very straightforward. A con is call. In the operating theater, you are going to be on call, and it's not just for the physicians. The nurses also are going to have to be on call because the surgeons and the physicians need the nurses to do surgery in the operating theater. This is something that nursing school didn't teach me at all. When you're in the ICU, step down, emergency department, or med-surg floor, or even outpatient clinics, they don't really know what call is, because in nursing school, call is generally associated with physicians or nurse practitioners or physician assistants. But in operating theater, everybody who's in the operating theater and has a role, they're all going to have to be called in because of the surgery. Depending on the hospital and the contract you're with, some OR nurses will get calls, some don't. Currently, me being on orientation, I'm not on any call right now, but once I finish my training, I will be given a few days of call per week. But that doesn't necessarily mean that if you're on call, you're going to have to go to the hospital. That just means that if a case were to arise and you were on call, then you'd be called in. So if you were on call, you would have to be within 20 to 30 minutes of driving distance from your house and the hospital, which can kind of limit your ability to live. If you were a nurse in other specialties where you're not expected to be on call, then you can theoretically live an hour away or 2 hours away, or however long you want. A way to kind of counteract that is if you do live farther away from the radius needed for you to make it in time in the hospital. Many hospitals do have call rooms, not just for the doctors, but also for the nurses. In my hospital, they do have call rooms for nurses as well. So even if you do live more than 20, 30 minutes from the hospital, you can just stay at the hospital when you're on call. So that way it's quicker for you to get ready for the case if the surgery is warranted. A pro is leaving early. On some days in the operating theater, you're going to have only a few cases. And if you have less cases, that means if you're done, let's say 2 or 3 hours ahead of time, you're pretty much going to be you'll still be at the hospital, but you'll mostly be assisting with other tasks. Sometimes you'll get to leave early depending on the day or the unit. I remember when I was in nursing school, there was other units where nurses would be waiting 1 or 2 hours later overtime just to get everything situated for the next rotating nursing team to come in. And that would be delayed in terms of giving bedside report to the new nurses that would be taking over. In the OR, bedside reporting doesn't exist. You only give a few minutes report to the PACU, and it's only on that one patient. You're not giving report to 5 or 6 other patients in the OR. And that's also kind of another pro in that sense. So you leave early and you don't have to worry about staying overtime for giving any type of reports, or you haven't gotten all of your ducks in one pond. A con would be gossiping and inappropriate conversations. I have witnessed kind of unprofessional communication, cursing and swearing, and inappropriate jokes being made for the entire team, and they will make a laugh out of it. I try my very best to avoid those interactions because my focus is on the patient more than the conversations the operating theater teams have, but you will get surgeons, nurses, anesthesiology providers, and other types of OR professionals kind of misbehaving at times. And it's not that they're bad people. It's just sometimes it can be a stressful environment where they talk about things that are not relevant to the case, and sometimes that can escalate to being inappropriate, but in a very laughing manner or in a joking way. Sometimes it does get serious, but that's something I've kind of noticed. And for me, it should be more about honesty, integrity, and still having fun in the operating theater, but without the need of kind of misbehaving or lowering your expectations for professionalism or behavior. Pro is integrated morning and afternoon breaks, time between cases, and obviously lunch breaks. If you're in other nursing specialties outside the operating theater, you may not get any morning breaks or afternoon breaks at all. And in some cases, you may not even get a lunch. When I was in my rotations, we had lunches probably a couple hours later than scheduled. I know some of my friends in nursing school that are on the floor, and they haven't gotten any lunches at all, which is kind of crazy. It's just kind of mind-boggling. In the OR in my hospital, you are given a 15 to 20-minute morning break before lunch that is paid. You'll get an unpaid 30-minute lunch. Realistically, though, people would spend maybe 35, 40 minutes on lunch. And then you'll get, sometimes, depending on if they are in surplus of staff, you might get an afternoon break, which again is another 15 to 20 minutes, and it's also paid. So one of the perks of being in the ORs is that you're going to get breaks quite often, and it's not that it's rare that you get those breaks, it's kind of expected. And in other nursing specialties, you don't get breaks at all because of the patient load you have. A con would be dead-end opportunities for education and not really using your clinical skills. So in other nursing specialties, specifically on the floor, you're going to have nurses that are going to have the opportunity to apply their clinical skills and kind of climb up the clinical ladder and pursue further education that's going to help them at their current job. So for example, if you're an ICU nurse and you really like critical care, a lot of those programs incentivize you to go back to school to get, say, a nurse practitioner degree, and then you can be still in the ICU, but you'll have a greater scope of practice in terms of what you can do for patient care. In the operating theater, the most nurses really can do is first assist, but that's really the pinnacle or the top of what you can do as a nurse in the OR. You're not making any clinical decisions at all. In my hospital, I didn't apply any of my nursing license in the operating theater. I was mostly learning about technologies, wiring equipment, robotics, laparoscopic instruments, surgical instruments. It was more like an engineering and hardware job at times than really a clinical job. The responsibility of that is really given to the anesthesiology providers and the surgeons and the surgical team. So they're the ones that make the medical decisions. The nurses are mostly just there to focus on more the equipment side and more the managerial role in the operating theater. That's kind of what can make it sometimes a dead-end specialty. A pro is the interprofessionalism and always having immediate support. In the operating theater, you are never alone. Ever. You're always going to have either a doctor, a nurse, a surgical tech, a sales rep, or a student with you at all times in the operating theater to assist each other and also collaborating with each other to get over challenging times. I remember when I was on the floor, I felt very isolated, not just psychologically, but literally, where I wouldn't see other nurses or doctors in maybe even the same unit. They might be in a different floor, or they might be in a different unit taking care of other patients. So at times it would be super lonely. If you needed some help or assistance, you would have to wait quite some time for them to get back to you. But in the operating theater, because everybody's there in the same room, you have instant feedback, instant communication, and you can get help when you need it if you immediately ask. And in contrast to other floor nursing specialties, that's kind of a pro in my sense of what the operating theater provides. A con could be getting up really early in the morning. I don't consider this a con because I'm an early bird. I generally wake up at around 5:30. I am up and ready to go by 6 a.m. and I get to the hospital around 6:30 to start my shift at 7. For night owls, it might be discouraging because the vast majority of surgeries, except for trauma surgeries, are scheduled way in advance and are typically done in the early morning through the afternoon. Now, that doesn't necessarily mean that if you're not an early bird, you cannot be in the operating theater. They have a dedicated night team in the operating theater that handles trauma surgical cases. So that could still be an opportunity for you. But if you're doing a regular staff job, the vast majority of the time, if you're in the operating theater, you're going to be doing days. And when I mean days, it's early morning until mid-afternoon. Another pro is there's little to no charting. In the OR, nurses have 3 distinct roles. They're either a circulator, a scrub, or a first assist. If you are a scrub nurse or a first assist nurse, you don't chart anything at all, period. Your focus is directly assisting in the surgeries alongside the surgeon because you are within a sterile field and you're not going to be able to document and pass instruments or first assist in the surgeries all at the same time. But because of that, the only person that documents in the operating theater on behalf of all the doctors and the nurses that are helping out in the surgery is a circulator nurse. However, the charting is very quick, it's very user-friendly, and most nurses finish their charting in about a couple minutes. It is very usual for the nurse to kind of get done charting within the first 5 to 10 minutes per case. So the electronic health system that's used in the operating theater is completely different than what's seen on the floor. I remember when I was on the floor, they had a completely different electronic health system, and the way that it was formatted was very detailed. Sometimes I would spend hours just documenting my head-to-toe assessments, and it was very frustrating and overwhelming at times. But in the OR, the major issue to your practice is not going to be charting at all because it's very user-friendly, it's super quick, and it's very simple. That's all the pros and cons I want to share about so far. I will conclude by saying this. When I was in nursing school, I wanted to go to the operating theater since day one. I was considering going to the floor, either the med-surg floor, the intensive care unit, or the ICU, the emergency department, or the step-down unit. But the OR really clicked with me, and that's kind of a place I always want to end up going into, and I'm very fortunate enough that my first job right out of nursing school was being in the operating theater. I really like many of the pros and benefits it comes with. I try to make sure that the cons don't bog me down too much. Overall, I think it's a great specialty, and it's certainly going to give me an extra boosting advantage when I get further medical education in the future. I know that I can't really utilize a lot of my clinical skills in the operating theater, but I do know it's going to provide me a good stepping stone and a foundation for applying those clinical and medical skills later on. My only suggestion really is I think nursing schools should really start to integrate and market the operating theater to nursing students at the same frequency and the same rate as they do with other specialties. I understand that most nurses generally go out on the floor. In my case, I only knew one other student in my cohort who went to the operating theater. Everybody else just wanted to go to the intensive care unit, the step-down unit, the emergency department. Very few did want to go to a med-surg, but they went to a med-surg, either a general med-surg or a specialist med-surg floor, and some went to outpatient clinics. But I think if nursing school really tries to orient a lot of these pros and cons I've talked about the operating theater, that can give other future nursing students or even other current nurses in other specialties to consider it and see if it's right for them. Surgery changes every single day, so the stuff I am sharing right now may not be what is come a couple years down the road, a couple decades, or a couple 100 years down the road. I appreciate you taking the time, and many thanks. And as always, cheers.